today. I'm Laura Kolaskowski, and I'm the lead patient representative for iConquer MS. And it's always exciting to be able to invite new people to come learn about us and what we do, and to welcome back our regulars who attend these talks. You're observing Chat with Chat. That's named because our usual moderator is Chat, but he is on vacation today. So today we have a guest host with Holly Schmidt, and Holly is our co-chair of the iConquer Research Committee. And I'm trying to advance my slides. There we go. So I believe most of you are going to be familiar with iConquer MS, so we're not going to spend a lot of time today talking about that because I really want to get to our guest speaker. But I do want to remind you that there are a number of ways that you can get engaged with us, and you can do it from the safety of your home and through the convenience of your laptop or your iPad or even your phone. There are several projects that we have going on right now. One is Real MS, which is research engagement about life with MS. That's our longitudinal study about MS and activities of daily life and the way we're affected. And that information helps to feed our database, and that's been ongoing for a number of years here. From that information you enter about Real MS, that's where we come up with the people that we say, hey, would you like to volunteer to help with this group or this focus group, or help us design a new study, or even the execution of studies. So it's really critical, if you want to step up your involvement with iConquer MS, that you get involved with Real MS. We also have on our website at iConquer MS the Our Questions Have Power program, which is where we're able to submit our questions, our ideas for research, and the community votes on them. We collaborate on addressing those questions that are the highest priority for our community, for those of us who have MS. So I hope you will take a look at that and also participate in the Our Questions Have Power program. Something that came out of our Questions That Have Power program was our COVID-19 MS study. We found a lot of questions where people wanted to know more about COVID and vaccines and COVID and MS side effects and COVID, which we're all still talking about. And we're still also collecting information from people about your experiences with the vaccine and also with MS. So hopefully you've joined our COVID MS study. You can do that also from your iConquer MS webpage when you log in. Join us at the COVID-19 study, please. That's really critical. And we're to the point now where people who have gotten vaccines and boosters and additional boosters are entering all that information online. And we're actively using that and getting ready to launch another exciting step with this, which will be the collection of biological samples from select people within that cohort of COVID-19 participants. Which brings me to the topic of today, COVID-19, for the curse that it brought us into our lives as sticking us at home. I really try to look at the glass half full perspective. And one of the really good things that perhaps happened out of COVID-19 was the access to telemedicine. And that was something that we had struggled with for years, saying, well, why can't I just phone it in? And all of a sudden now we're being told we have to phone it in. So I'm really thrilled that we can talk today about this topic. And at this point, I'm going to share my screen with Holly Schmidt, who's going to introduce our guest speaker today. Again, thank you for joining us. If you're not already a member of iConquer MS, go to www.iconquerms.org.
Thank you so much, Laura. That was a great introduction. Everybody, I'm Holly. You've probably seen my name on emails. Usually our host is Chat, and Chat is on vacation. So we're not doing Chat with Chat. We're doing Chat with Holly today, and I'm really delighted to be here. So thank you all for coming. It's my pleasure to introduce our special guest today, who is Dr. Mitchell Wallin. Dr. Wallin is a neurologist with the Veterans Administration at the Washington, D.C. Medical Center, and he is the director of the VA's MS Centers of Excellence East. He received his medical and public health training at the University of Minnesota and Northwestern University and Johns Hopkins University. In addition to his work at the VA Center, he also holds appointments at Georgetown University and the University of Maryland. Dr. Willin has been a close collaborator of iConquer for several years, and today he's going to share some results from a study that iConquer played a major role in. If you were a member in early 2020, you may have seen an invitation to take a survey about your experience with telemedicine. Well, right after we conducted that study, a little something called COVID-19 came onto the scene that, as Laura mentioned, caused a lot of our healthcare to take place over telemedicine. So we repeated the survey in the fall of 2020 to see what had changed. We're now going to get to hear some of the results from these surveys and other parts of the study as well. And there will also be some time for Dr. Wallin to answer your questions. Thank you to everybody who sent in questions through the registration form. And we also invite you to use the chat function if any other questions come to mind during the presentation. And I will now hand the floor over to Dr. Wallin. Please take it away.
Thank you, Holly. Appreciate being here. Can you guys, first of all, see my screen okay?
Yeah, looks great.
Can you hear me?
Yep, you're
Okay.
great.
Thank you to Laura and the whole iConquer MS team for inviting me today. Happy to be here and talk about some of the data that many of you, or some of you maybe on this call, participated in. And I know as we continue with the pandemic, telemedicine has been and continues to be a part of our care delivery system. So I want this to be interactive. I will try to provide some background and give us some context to have some questions about this and get your feedback. So no disclosures to present today. I wanted to start with a case, and we can talk about this more going through. But this is a 41-year-old female with active relapsing remitting MS, onset in 2013, moderate disability at EDSS-3. She started on a new MS DMT in March and is visiting family in another state. After arriving via airplane, she developed some upper respiratory symptoms and was tested positive for SARS-CoV-2 at a nearby ER. She was advised to rest in quarantine for a week. The respiratory symptoms persisted over the first 2 days, and she developed some sensory loss in her upper trunk and had an upper body rash. She calls the clinic for advice. She missed her appointment this past Monday, and she was supposed to, at that time, complete some surveys, do an exam, and do some blood work related to her DMT. So how could telemedicine be used to assess this patient? And she asked about acute treatment for SARS-CoV-2 and how would one bill for this kind of a visit. So this scenario probably has happened maybe to some of you on the call. I know it's happened to us as providers, but it's a common occurrence. So I wanted you to think about that as we're going through. So here's the topical outline of what I'd like to cover in probably the next 35 minutes or 40 minutes. Understand the application of telemedicine to MS, assess some of the utilization trends, and look at some of the feedback that we've gotten from patients, providers, and payers, and then have some discussion time. How do we define telemedicine? I think this is a fairly succinct definition: the use of technology to provide access to clinical care when distance separates patients and providers. And there's various formats for telemedicine. We divide them into three main buckets in the literature. CVT is clinical video telehealth, using internet-based video conferencing between patients and providers and to communicate and do an exam. There's store and forward technology, where you use technology to asynchronously acquire, store, and forward information. This could be like a optic scan or some other information that's forwarded, or potentially even a survey. And the whole area of home telehealth, where there's maybe mobile monitoring for falls and step counts, or messaging or video coordination of neurologic care. And this could be synchronously at the same time or delayed sending of information. So we were given some funding by the National MS Society to look at telemedicine and MS over the last roughly 4 years. And we did this study before the COVID-19 pandemic kind of started. So we didn't have a plan, in the wings, but we used the pandemic to help us assess telemedicine as it really took off. But this was a review of literature really prior to that pandemic, between 2000 and 2018. We included all peer-reviewed articles. We had some exclusion categories there, as you see, and we used a quality indicator called the CASP to rate everything. And there had been a previous review in 2015. So we looked at all the literature and we found roughly about a little under 30 studies. And most controlled studies showed no significant difference or even a beneficial effect from telehealth interventions versus standard care in patients with MS. And most interventions in this review were low cost to implement. There appeared to be improvement overall of well-being and mood in several studies, but there was quite a range of quality and validity based on the CAS score. So some studies were real well done, some were just kind of case reports or kind of intervention and post hoc that left a lot of questions. These are some of the summary findings. The three buckets that we divided this into are general MS telehealth, rehab, and then mental health and neuropsychology. And so most of the studies were around the management and disability assessments of patients with MS, and they showed that good uptake in these studies, and patients in generally providers were impressed with what could be done. There's this one remote intervention I'll point out here, but it did actually transcranial stimulation in the home through CBT, which I thought was kind of interesting and innovative. And a number of studies looking at home rehab and fatigue management. And these were all done prior to the pandemic. And then looking at how we can remotely examine somebody, we've done work in the VA side, and it's been used in other clinics and settings throughout the US and in other countries. And looking at EDSS, the most common rating scale, which is basically a detailed neurologic exam. And we did this remotely and with high-end cameras, and had basically advanced practice provider, either a PA or an MP on the other end, doing the exam, and we compared the ratings of the live examiner versus the person that was examining remotely. And the bottom line is that we got pretty close correlation between the EDSS scores on both ends of the live person doing it and then the remote person doing it and rating it. But this is with the help of a mid-level provider on the end there. If you look forward to a more current study, this is from the UCSF group. They looked at the live EDSS followed by a remote exam within a week by a different clinician in the home without a provider or anybody there. These are the demographics of the patients, but the mean difference between the remote and the live EDSS was 0.34, which is pretty close to what we even get in two live exams put together. There was some variation in individual functional systems, vision being the lowest correlation and bladder being the best. These were people that were mild to moderately impaired with their MS. So they were not using a cane, but they were between basically 1 and about 5 on the EDSS scale. So what are some of the advantages and even opportunities for telemedicine based on some of the literature that we have? Obviously, time savings, you increase the delivery of MS and specialty care to underserved communities that maybe can't access it. No-shows are basically much fewer in a telemedicine environment. You have fewer excuses to not show up to clinic. They're optimal for weather emergencies and offer a means to deliver care exactly when it's needed. So like an exacerbation or when something really is going on, you need to talk to somebody. And they potentially have a lot of cost savings over other forms. And increasingly, neurologists are doing this as a career choice. Telestroke is caught in a big way, but also all kinds of neurologists are actually going into telecareers, and it's really opened up over the last few years. Challenges include the reimbursement process. I think during the pandemic, a lot of insurance companies relaxed their insurance and billing so that pretty much everything was covered. It's really kind of gone backwards a little bit the last 6 months. There's some cost issues if you're doing some store and forward or remote monitoring, but largely I think these equipment costs have been equalized, and it's pretty easy to get equipment in internet connection. There are some safety and liability issues, falls, or even people with other comorbid diseases getting into problems in the home environment. And there's actually been some more interesting legal challenges with people doing telemedicine, possibly needing a different or new kind of malpractice. You can imagine the case where you miss a stroke, where you miss somebody that has appendicitis, when you're looking and working remotely. So it's a question if we have a different standard for telemedicine than we do for live visits. There are many places in the country that don't have high-speed internet. And then the big kicker is that people usually in a traditional patient-doctor relationship in the private sector have to have a license in the state where the patient lives. So that really puts a kibosh on going across state lines, especially like in the eastern region where states are fairly close to each other and people live in different states. This is one of the first studies we did. I would say we looked mainly at the VA system. We did this before the pandemic, but we incorporated 2020. On the left panel, you see all the cases of MS with a telemedicine or telehealth utilization, with white being low and red tones being high. This is a matched control population to these cases. And you can see between 2010 and 2020, the utilization for that year in telemedicine was much higher. It got higher through that decade, but also was much higher in MS cases compared to controls. So we see almost double the number of telehealth utilizations in the MS cohort throughout the country compared to controls in every given year. And then there's about twice as many telemedicine cases in 2020 as there are in 2010. So this article is almost going to be let out in neurology clinical practice soon. But I will tell you, we tried to do this in the private sector databases, and we couldn't get enough cases to even do it for 2010 and 2016. Our hypothesis was that basically there may have been some telehealth or telemedicine going on in those years, but they weren't coding for it. Nobody was coding for it, so we couldn't pick it up in the encounter data. So this is some of the summary points. Patients with MS were twice as likely to get a telemedicine visit than their matched controls. Increases in telemedicine throughout the decade. And I guess we can say that we've been promoting telemedicine for many years, even prior to the pandemic. So we were able to, what I'd say, swim when everybody else was just jumping in the water. But we need further work to see what were the determinants and risks for people either using or not using telemedicine. This is a study survey we did of providers that is going to be published soon in International Journal of MS Care. One of the residents from GW helped with this. We had a 34 web-based survey that was created, and the responses were analyzed in Qualtrics and SAS. We got 91 people to participate. You can see the types of healthcare providers here. We sampled every region of the United States. We looked at all different types of telemedicine platforms, and most people had quite a bit of experience. They're at least 5 years into their professional work life from graduating. Just some snapshots here. This is the percentage of respondents agreeing with the potential advantages of telemedicine. So these are various key points. The top three things that providers thought that would be a benefit to telemedicine, including better access for patients, number one. Number two is greater convenience for providers. And number three, lower costs for providers. And then here's the percentage of respondents agreeing with the potential disadvantages of telemedicine. The biggest disadvantage is more difficult to do a full exam, and then more difficult to communicate due to technical issues is number two. Number three is concerns about privacy and security. Some more questions about satisfaction. How satisfied were respondents with their last telemedicine visit? So most of these responses were during the pandemic. We had a handful of data prior to the pandemic, but most were either very or somewhat satisfied. If you look at how likely were respondents to want to continue using telemedicine, most said that they definitely would. A few not sure. There was this curmudgeon group here that didn't want to do it. And here's telemedicine pre-COVID and during the COVID pandemic. If you look at the blue bars, those are people that use telemedicine, and then oranges that didn't use. So basically, we're well under 10% pre-pandemic survey. And then if you look at the pandemic, not a surprise, over almost 70% were using, and still about 10% weren't. If you look at of the providers who use telemedicine, what percentage of their practice do they dedicate to it? Pre-pandemic, probably 10%, and then post-pandemic, almost close to 100% with quite a bit of variability. So some of the follow-up kind of wrap-up comments from this survey, providers thought telemedicine provided enhanced access to patients and a safe way to assess people during the pandemic. There were some technical issues, connections to people, lack of equipment, both on the provider and the payer side, depending on where they were sitting. But it was felt that telemedicine lent itself to particular specialties and subspecialties more than others. So subspecialties like headache that are predominantly based on history are more amenable than like exam heavy specialties like people that have do EMGs or even potentially MS. That was kind of the feeling there. The strengths of this study was fairly diverse in terms of geography and specialty and age. The sample size was a little small, but we got a decent sampling across various types of providers. And we were able to actually assess pre-pandemic to post-pandemic. So this was the study done in the iConquer MS group, and you'll see many of the people on the call here that participated in this. We have a survey one group, which looked at people in group A here that took the survey pre-pandemic, and group C, which took the survey after the pandemic. Or actually, they actually took it twice here. And survey B only took it during the pandemic. So we had A, a pre-pandemic group, B, a intra-pandemic group, and C, there's the group that took it twice. So you can see the breakdown here, 25 to 33% response rate. So here is just the numbers again here, in-person healthcare versus telemedicine, looking at groups A, here was the pre-pandemic group, B is the intra-pandemic group, and C took it twice. And so you can see telemedicine overall, pre-pandemic was actually people participating was around 20%, and then upwards of 80% of people were participated in telemedicine during the pandemic. Here's some of the demographics of the people with MS. Generally 15 years after diagnosis, most people were in the relapsing remitting phenotype, some with secondary progressive and a smaller proportion with primary progressive. Most people, 80+%, were taking a DMT. Preference for telemedicine among patients with MS. So I think it's probably easiest to look at the longitudinal group C, where you have time point 1 and 2 in the same group. You can see the change. Basically, I would like to use telemedicine for most or all of my MS healthcare. Only a fairly small percentage, pre-pandemic, 11%, and then almost 19% here post-pandemic. It's kind of in the middle. I would like to use telemedicine for some of my MS care or occasionally for my MS care. That was the bulk of the group here. And then here, I would not like to use telemedicine for any of my MS care. About 10% said that. And then some people weren't sure. What were the advantages of telemedicine from the iConquer MS group? So protection against being exposed. I mean, we could basically, most people thought that was a good reason to do that. And then look at better access to services or specialists, about the same pre and post pandemic, greater convenience for me. Again, most people, 80%+ agreed with that pre and post pandemic, lower costs. This is actually more of a advantage pre-pandemic than post. I'm not sure why. Better interactions with the provider, a small percentage, and then there's a few other things. And then there's this group, 8%. I don't think telemedicine would provide any advantages for me. 8% felt that. Here's the disadvantages. More difficult to communicate with my healthcare provider. About a quarter of the people felt that was an issue. Concerns about privacy. Initially, 22% went down to 13% during the pandemic. More difficult to receive a full exam. Majority of people felt this way, almost 90% on both sides. And then a cost or healthcare coverage issues. Initially a barrier in a quarter, and then about 10% said it was an issue during the pandemic. I do not think telemedicine would present any disadvantages for me. Again, about 8%. So pre-pandemic, this is a summary of the data from the surveys. Saving time spent traveling was one of the most frequently cited advantages, followed by better access to specialists. As we got into the pandemic, we observed the same dramatic increase in the use of telemedicine seen across the board for other specialties. And then before and during the pandemic, a large proportion of participants indicated that there was a preference for using telemedicine for some, most, or all of their healthcare. A significant proportion of this, the patient population expressed a preference for using telemedicine for at least some services, especially nutritional consults, general MS care, mental health services, social work, and primary care. The most frequent cited disadvantage of telemedicine was that it was more difficult to receive a full exam. Patient preferred in-person care for the more hands-on specialties, including neurology and surgical care. So this is one of the final studies we did with the University of Maryland, looking at specific interview comments from their experience with telemedicine. So these were the interview questions. Tell us about a memorable experience with telemedicine. What worked well, what didn't? Whom do you think telemedicine would work best for, and why? How do you see telemedicine being part of your care in the future? What would you like to see improved, and why? We interviewed 20 patients. These were in-depth interviews. You can see fairly diverse. Average is 56 years old, balance of urban and rural, and various disabilities. We had 15 providers from a variety of types, all caring for patients with MS. Average of 17 years in practice, various settings, and they all used telemedicine. So we put them into buckets. This is practicalities, increased access and convenience. I'll just go through a few of these. You can read them as I put them up. These are kind of the classic quotes, and they were put in the article in a more systematic way, but I live 2 hours from my MS center. It's all turnpike driving, it's stress driving. So telemedicine is awesome. That's 4 hours of my day that I don't have to be in a car driving and paying tolls. It's a female patient, 62 years. Here's a psychologist, 5 years in practice. It's the difference between treatment and no treatment for those folks who have a tough time getting to the facility, affording the bus, being able to park. Some technical challenges. We kept on having problems. The video or the sound wouldn't work, and we're just kind of going back and forth. It was kind of awkward when the other person can see you and they do things that they think they think nobody's looking. In the beginning, I was like, okay, how are we going to do this? I could probably assess your cranial nerves depending, but some people's camera are crappy or the connection's crappy and it's pixelated and you can't see. So I'm sure you can experience, you've had that kind of experience on Zoom calls like this. So this is a patient perspective. Can you really assess me in this way? I have foot drop with MS and my neurologist can't really gauge me walk too well. And then grip strength and my balance stuff. He could kind of assess because I do stand up and he has me close my eyes, but I don't know if he could really fully assess that. Televisit with my neurologist was just mostly like, how's everything going? And I did do a balance thing with him and a couple little things. But yeah, the eyes, we didn't really look. So you can only gather so much from a camera or a phone call. Can you really assess me in this way? It depends. If the provider is familiar with me, I would hope that they would know how to judge by talking to me. If they need me to put the computer a little further away, they can watch me or walk or do whatever. Then they say, let's get you onto an MRI, and that can be done over telemedicine. So there's provider skill in asking the correct questions. I can't think of anybody that telemedicine wouldn't be beneficial for. I mean, Like the doctor said, 90% of the time when it's face-to-face, asking the right questions is key. So when is a telemedicine visit appropriate? I guess for patients that you know well, I think the telemedicine exam is sufficient. Typically for just routine visits, I'm looking at the MRI, I've looked at their labs, and I think that a televisit is perfect. For patients with a new complaint, I want to see them in person. So here's a clinical experience from the provider's perspective. As I'm doing more visits with audio and visual, I'm sort of improvising some exam kinds of things. I feel that I'm getting a little better at doing some more things in terms of looking at gait and actually, to a certain extent, eye movements. A lot of learning how to provide care via telemedicine was kind of trial and error, talking with other providers. The apprehension of a neurologist has definitely really been lowered, having seen how much they can get done via telemedicine. Patient experienced less stress. I actually felt like the neurologist was paying more attention to me. I've never had the televisit interrupted with a pager, but I have when I'm in person. Providers have more time to be present in those meetings because there's no travel involved. There's no rushing from room to room. Only if technology works well. Patients want to do a good job on this, and if they're not comfortable with technology, it makes them very anxious. This patient, 37-year-old, was given news of a new diagnosis of MS. That's a brutal way to get delivered this message. Hey, you have MS, and then just close the window and just close the laptop. What happens on the other side of that with the person that is hearing that information? Cultural shifts and managing expectations with telemedicine. I felt like I got ripped off here. How do you know my heart's okay? How do you know my lungs are okay? The whole thing with telemedicine that I don't like is that a nurse doesn't room you. So you go direct to the doctor. You don't get another person saying what your complaints are. I'm just talking with you, getting vitals. That's a big thing. It's just important for doctors to take these telehealth meetings as serious, the same intentionality, so that you don't feel like you're just phoning in, to use a cliche, that you really feel that they're there at that moment, even though they may be in their house, study, or wherever. They really use the same decorum and professionality that they would if you were in person. So some good ideas that bubbled up from our interviews before and during the visit. The office visit is almost like a good movie that has a good beginning, a middle, and an end. That start off and you look back to what you did before. And then let's take a look at what the situation is now, and then have some goals for the future, especially if there needs to be a change in medication or whatever. I feel like it should be thorough is the only word that I can think of. You really feel confident that the doctor's looking at the whole picture, not just checking off a box. You don't get a chance to finish the appointment. It's like, okay, I got to go. Okay, but then you don't talk to anybody else. You hang up. So I just left the appointment. What's my next step? Yeah, that's different and weird. Always get a backup phone number. I'll follow up lab work, scheduling new appointments. Referrals need to be all clearly communicated. So some key takeaways: patients need telemedicine, especially if living far from an MS specialist, and especially as the disease progresses. Hearing and seeing well are critical to a successful telemedicine experience. Patients take the lead of their providers as to what is possible to accomplish via telehealth, and managing expectations of what constitutes a visit by being prepared and understanding what to expect. So we talked a little bit about from all these series of interviews, we had a lot of data back. I just shared some of the summary points we thought were interesting. Overall, telemedicine, it was felt to be efficient and convenient platform for many aspects of MS care. I think we'd say additional training for many MS healthcare providers is needed to expand telemedicine as a routine care delivery platform. And there are things that we can do to improve the exam and make it more accurate. And there are technological solutions that could fill in some of the gaps for remote assessments. But given the proven value of telemedicine, stakeholders should work with the state and federal government to preserve and expand policies to cover it, like we had in the pandemic. Just a couple final things here. Remote monitoring has come a long way, and this is a study done by Valerie Black, who's a physical therapist at UCSF. 94 patients with EDSS less than 6.5 and intermittent follow-up for a year. She recorded patient-reported outcomes at various intervals during the year, and also had a step count. Half the patients reported falling at least once, and about a half with falls. They couldn't find evidence of those recorded in the electronic medical record. So here's some people comparing people that fell and didn't fall. So she wanted to actually look at ways you could identify those patients. This is the step count with kind of a Fitbit, a modern Fitbit between people with no fall and fall. Here's a 25-foot timed walk, and that separated people fairly well, timed up and go. Again, a little bit of separation, not as steep as the other two. And then here's a MS walking scale, it was pretty good. And if you look at all the ways that they could identify fall risk, this is a variable importance plot looking at the most important variables at the top with the biggest bar. The MSWS12 baseline was consistently in the top 2 most important remote fall risk predictors. So this PRO can be potentially pretty helpful in predicting fall risk, but they found also that the step count was fairly good as well. There's a lot of smartphone apps that can integrate things. And so this is just a tracking here of time and disability for MS. And the orange are actually in-clinic outcomes where they would measure disability. And here's a sensor outcome of an integrated tool used by patients. So I think we're going to be seeing more of this, and this kind of data could hopefully help to manage and track changes over time much more accurately than just the intermittent exam. So some conclusions, MS providers predominantly used clinical video telehealth as their main form of telemedicine and were satisfied with its use in general. There's that 10% that didn't want to have anything to do with it. There was an increase in our CBT and telephone-based platforms during the pandemic, and more limited use of other forms of telemedicine, like store and forward or more monitoring kind of things in the home. I think addressing some of the technical issues and providing more effective tools to perform a remote exam will improve its feasibility. And I would just say, look at the banking world. That doesn't have a lot of the same, but 25 years ago, people were still going to banks by and large. But I think we've overcome some of those hurdles through technology about just dealing with things and being able to bank remotely. Telemedicine can provide a valid alternative to in-person visits. Maybe not everyone. I think most people felt that the first visit and when you required a more detailed exam, obviously the in-person is optimal. Further studies needed to evaluate health insurance reimbursement issues for telemedicine and what barriers may exist that are limiting utilization, including store and forward and remote monitoring. So I think we were in the kind of honeymoon period during the pandemic for telemedicine, and people were trying a lot of unique ways and platforms to try to assess patients remotely just because of the safety issues. But I think we need to continue doing that to find the best place where this fits into the whole healthcare. So I bring up our case again of our female MS patient that got stuck in quarantine away from her clinic. And I thought we could maybe talk about that a little bit, but I want to, obviously we have maybe about 15 or 20 minutes here towards the end to deal with some of your questions. I was able to write some of them down, and I think I'd be willing to go through these first. And I'm not sure if we have to, if it's okay, if you want me to go ahead with this, Holly, or if we should do it in a more general way.
I've got the same question, so why don't you go off of screen sharing,
Okay,
and I kind of group them into some buckets, so
I'll get off here.
and we can, yeah, see everybody here, and the chat is open if anybody has a question that comes up in the meantime. And thanks to it looks like Laura and Seth have popped in a couple of, well, so we'll work those in. So one question, and it gets into Seth's question also, is, what do you think are the major shortcomings of telemedicine? What is it good for? What is it less good for? Can you really observe a patient thoroughly via Zoom? How do you determine walking ability? Is it really better for people that you've worked with a while? Or could you also do a diagnostic visit with telemedicine? What do you think?
So I would say the first visit should be live, and I think it works best for people where you know their baseline. I'll just say that to begin with. I mean, But there are people sometimes where you have a second opinion. I think if you had to look at just an e-consult or a telephone call, I think the televisit gives you extra tools. I would say that most providers that I've run into have not really been trained effectively in doing a remote exam and what you can do, what you can't do. And I think we maybe need to do a better job of teaching that as part of the residency. It's done pretty effectively with the NIH stroke scale, which is largely ER medicine, where you're doing the acute evaluation. And typically that is done with the help of observers or nurses or the people around. If you have, I know we've shown in some of our studies that when you have an aide or even an advanced practice provider with the patient, you can do a much better exam. But that, I guess, is not what most people have. I mean, so if you do a telemedicine visit remotely to a primary care clinic, and if you have somebody there to help assist you, I think your reliability goes up dramatically. And we showed that through that initial publication where we had, for 2008, pretty good cameras, Polycom cameras. We could zoom in on things. And even with the functional system scores, we got pretty close in every functional system to what was going on live. So the bottom line is I think the initial visit should be live. And when you really need to, when it's important to really get a good exam, I mean, you need to do that, I think, live. But I mean, there's really niche places where if you know somebody and somebody is calling with a major flare up, try to differentiate if they really need corticosteroids or something else may be going on. Or if you're going over a follow-up MRI, labs, I mean, it's ideal to do that through this kind of a venue.
Right, great. What about if somebody doesn't have a camera or doesn't have a really good camera? That was mentioned as one of the comments, or maybe their bandwidth isn't great and they can't share video. So what can you accomplish with just audio?
You can obviously there's a number of surveys. We talked about this last study that was done to predict falls. So the MS walking scale was the best predictor. You could do that through a televisit. And there's a lot of surveys and things you could do and get the history. You can do the PDDS, which is used to look at disability. So there's a lot of things you can do on a phone call that you can assess what's going on. It doesn't give you the full granularity that exam does along with that. And there are parts of the country I mentioned that don't have good internet. And I think to push to try to get that. In some ways, they're trying to push better cellular service to some of these areas. I know some clinics, we give out very expensive prosthetic devices. In the military and the VA, they're giving out really nice tablets for people that don't have them, so they can get a camera and use and do telehealth.
Great. Is there anything people can do at home to prepare for their telemedicine visit with their neurologist? What do you like to see when you're doing a telemedicine visit with your patients?
So it's a good question. So there's a few kind of screen things you learn kind of through experience. You don't want to sit in front of a window where the light is coming behind you. It washes you all out. So sometimes that's not possible. People have one bedroom apartment, and that's the only place they can sit because that's where their desk is. But you try, if you have a tablet or something, even a phone, you can get in a position where the light is coming in front of you, and they have all these fancy things now that we do in Zoom all the time, where you can put the light, you have this little ring light, you can make it look professional. So just so you can be seen, and your screen and there's enough light in the room, I think that's really helpful to do a good exam. The other thing is if you can get in an area where you can stand up and walk a little bit. That's really hard sometimes, but in some cases you want somebody to stand up and walk towards the camera or away from the camera. So try to arrange those kinds of things ahead of time and talk about it, or have somebody else in the home that could be there if you need that. If you have issues with walking, is another helpful thing.
Yeah. On that topic, I've read that one of the helpful things about telemedicine is that providers can get a sense of their patient's environment and if there's any hazards or if they seem to be missing something or needing something. Have you had that experience, or have you heard that from your colleagues?
That's a good point. I didn't probably bring it up. There was actually a quote from a provider that said, I really didn't know how this patient was getting around their house. And when I was on the televisit, they saw the patient walking fairly effortlessly between rooms and doing a much better job than they had done in clinic in the past.
Hmm.
And so another case, somebody noticed that their patient was smoking, or they noticed, you notice certain things. It's kind of brought back the house call, you know? And I think we always talk about understanding people in their environment, but I think, the Zoom has done that. I know that there's people too that do home visits, to look at safety hazards just through the Zoom platform. I know physical therapists or sometimes nurses will do that. So there's a lot of potential ways we can use this in a better way, and avoid trips and that kind of thing.
Okay, very good. Another question that we got earlier was, can you speak to the privacy and data security risks of telemedicine? Is that something you have some insight into? And what can be done to address those risks?
Yeah, so I think that was one of the questions even before the pandemic. People were very concerned about platforms for video telehealth. Even Zoom, if you remember back around the 2000, right before the pandemic, there was security issues. People thought, but I think largely because of all the healthcare organizations and companies that have been using these platforms, they're certified. Some of them are certified as being HIPAA compliant, and they're encrypted. And so right now, most of all the Zoom accounts are used for healthcare. It's all encrypted. It meets a certain standard. There's a list of platforms you can get on the web that are encrypted the proper way, so they can't be hacked into, and it's secure. So I think those issues have been largely addressed by the internet companies. There were some platforms early on that weren't HIPAA compliant. But it's important to actually ask your provider, what platform are you using? Is it HIPAA compliant? There should be a consent process as well, where they bring that up at the beginning and say that we are using a HIPAA compliant platform, and that we're going to use this interaction here for your medical care. I think on the patient's end too, there's during the pandemic, you see maybe little people running around without clothes on in the background, or other things. So try to find a place that's private, so, but I think that the security issue has been largely addressed, but I think it's important to ask about it.
Okay. And then a related question is, somebody, I guess, really likes the use of MyChart through the Epic system that their doctor has, and they wanted to know whether those kind of patient portals like MyChart would be able to integrate telehealth, so you can just kind of pull up the one thing and use that for telehealth as well as other uses.
There are like Epic and some of the private EMRs can be integrated with a telehealth platform. I know I work at Maryland, and they have a specific company. They had a Zoom account, now they have a different account, but there are companies that can work with Epic or Cerner and deliver telehealth. It's not, I guess it's like Epic is kind of like a Honda. You can add the telehealth, and you can have different forms of telehealth be added. It doesn't actually come built with a portal like MyChart. So you have to choose the platform to integrate with it.
Okay, so some might and some providers might
Some
choose
might,
to. Yeah.
yes. Some clinics are more integrated and they're doing it. It depends on how it's billed and how they'd use it.
Cool. Um, Another person who sent in a question earlier said they really prefer in-person to telemedicine. So they would have been one of, the people who said, like in most situations, I'd rather go in person. But their
Mhm.
doctor seems to be pushing the telemedicine. Do you have any advice for them on how they can communicate their preference to their provider?
Yeah, I would just be very upfront saying you'd like to have an in-person assessment. There's some people that just like to go to the office. There's people that just like to be in person and enjoy the experience of being in the waiting room. But they want to do that. And so I think trying to ask for that preference. I think most providers have a time where they'll see people live, and trying to work that out. If that was during the pandemic, I kind of understand that, but most providers have clinics where they can see people in a face-to-face format.
Mhm. Okay. Um, Laura wanted to know, what are your thoughts about the future of telemedicine? Do you think it's here to stay, or payers going to be pushing back? I think you mentioned there might be somewhat of a rollback
Yeah.
that you've seen with payers. What do you think is going to happen eventually?
I think the pandemic it introduced to everybody how it could be utilized, and so I think it'll be a way to deliver care in some contexts where it makes sense. But the ultimate driver is going to be the payment. If you're not going to get reimbursed for it, it's hard to offer it, to be honest, unless you're doing um, a cash kind of practice where that's what people want to do. But I think the future is going to be um, based on how the states and how the federal government looks at some of these issues and what they're going to pay for upfront. They're going to have parity laws. In some states, they have this where if you see somebody for a condition live, it'll be reimbursed at the same rate if you see somebody and document it the right way through telehealth. Um, One of the kickers, I'll just be totally frank, is the facility fees. So you walk into a clinic, there's people that see you, there's lights, there's the building that you have. Those all have to be paid for, and there's facility fees that can't be charged when you do telemedicine. So to go to your clinics, to have the hospitals, the nice ramps you drive your car into, that all comes from somewhere. So there's a more complex economic things that with billing that can't be charged sometimes when you do a telemedicine visit
Yeah.
that the bean counters are very aware of.
And those are fixed costs, so they're going to be a presence whether or not you go to the clinic or not for the
Yeah, it's how
fee.
you bill for those indirect costs. It's a big part of it, of what'll drive things. But I think there's a number of advocacy groups, the American Telemedicine Association and others, that even the American Academy of Neurology, that see the value of this. And there's patient groups, even like iConquer or National Mass Society, that are push for telemedicine portals to be paid for and reimbursed at similar rates. Because I know for some people, it's a real life saving way to get care.
Hmm. And Patty also noted that the price of gas is something that, especially for people who driving, 2 hours back and forth or longer, that might also influence the benefit of telemedicine versus,
Mm-hmm.
having to drive to your clinic. So maybe that's another factor.
Yeah.
Um, she also asked about using telemedicine for those who live in rural areas, again, like the distance, price of gas, but also access to providers. Maybe that would be a factor in states that have more rural populations or providers or payers, insurance companies who have more people in rural areas and might benefit a lot more and have a difficult time getting access to quality care where they live.
Mm-hmm.
Do you have any experience with providing telemedicine to rural areas?
Yeah, like the whole state of West Virginia.
Mm, yeah.
So we have to cover, through the VA and the military system, the whole country, or when people are in different places. So we are regularly reaching out to people that live in the plain states. My colleagues in Seattle cover the state of Alaska. So there are many places where it would be really hard to get to an MS specialist, and so this really is very helpful. It way to do follow up to deal with things that come up acutely when somebody can't easily get to a practice. So yeah, I think especially for rural um, patients that live a long way from specialty practice, this could be very helpful and has been helpful, especially during the pandemic.
Yeah. Patty asked, I think we covered this a little bit, but maybe if you'd have anything else to add, do you believe that telemedicine expands a provider's ability to know a patient as the patient visit is conducted in their environment versus the provider environment? So I think you did touch on that a little
Mm-hmm.
bit, saying it can be helpful to know what the patient is doing or how they're living.
Yeah.
Yeah. Great. And then one other question is, you mentioned that the National MS Society funded this project,
Mhm.
and it was their policy and advocacy group that provided the funding because they want to know what they should be advocating for among politicians and policymakers to preserve access to healthcare for people with MS. So, have you been in discussion with people at the society about the study results? Do you have a sense of what they're planning to do with the results? Things like that.
Yeah, I think as all these studies get published, I think there will be an effort to use them for their lobbying efforts on Capitol Hill. Many of you participated in that in the spring. We had actually some some talks about that with some of the attorneys from National Mass Society. So the short answer is yes, and I guess has always been an interest in trying to see where both patients and providers their opinions lie and where the policies are going with these areas. But I think the, the studies we've done shed more light that it's important to have this as a platform, and it's sometimes the only way people can actually access a specialist if they live a long way or can't get out and can't get to somebody. And so I think, yeah, they're going to use hopefully these studies and use it in their lobbying efforts to try to maintain some of the same policies that were in place during the pandemic.
Wonderful. Well, that brings us to the top of the hour. Thank you all for being here. Thank you, Mitch, for Dr. Rudlin, for that wonderful presentation and sharing the results. And thanks to everybody on this call or out there in the world who participated in the surveys and the interviews and made this study possible. The recording will be put onto YouTube within a few days. So we'll send that link out. And so if you'd like to watch it again, refresh your memory about the results, or if you'd like to share the link with people who couldn't be here, then we certainly encourage you to do that. And yeah, I hope you all participate in the different iConquer MS activities that Laura reviewed. And if you have any questions about what we covered today, please contact us. We're at info@iconquerms.org. And we hope to see you at the next Chat with Chet, which will be coming up in a month or two. So have a good afternoon and evening, everybody, and thanks for being here.